What I was tasked to talk about today was biologic therapy in inflammatory bowel disease, not just in UC, and not just in Crohn's, but in all of it. So in 10 minutes. So it'll be a pretty sweet talk. Basically, what I'd like to try to do is just talk a little about the goals of therapy in treatment of IBD, what we want to do, and balancing a little bit of the risks and benefits, the risks of the disease itself versus the risks of treatment and how the benefits can help that. And then we'll talk about how our armamentarium has really increased over the last 20 years. It's really exploded. So here's some disclosures. So, the goals of IBD, and there are a lot of them, but really, what we want to do, we're in the business of doing as physicians, is making people feel better, right? So we want to get, first, people to have symptomatic improvement. And then ideally, on top of that, what we want to do is we want to make the mucosa look as normal as we can, mucosal remission. Because we found that if we can make the colon look normal, it's less likely to flare and less likely to need to come out in ulcerative colitis. And in Crohn's disease, if we can avoid the scarring and the fistulization and the obstructions and the abscesses and the need for surgery, then we can avoid those subsequent complications. As time goes by, the questions have even been raised that, okay, is it good to make the mucosa look normal, but wouldn't it be better if we could even make the biopsies look normal? And that's not standard of care yet, but it may be in the near future. And really by doing all this, we're trying to prevent hospitalizations, time away from work, school, friends, family, and we want to, prevent the need from surgery if we can. Obviously, we know we can't always do that, but that's part of our goals. So really, when we're choosing the treatment, like I said, we have to gauge what is the impact of this disease. We know that all ulcerative colitis is not the same. Ulcerative proctitis, mild, where people have to take some suppositories every once in a while, is not the same as in any way, or as fulminant colitis, where people are in the hospital really sick, life-threatening. And we need to balance, so what's the impact of the disease on what are the treatment options and what do we have available and what are the risks of those diseases? And that's something that we spend a lot of time talking with patients over the course of the weeks, months, and even years on what we want to do. And we have to really, in order to talk about doing some of these medications that we have, and we're lucky to have, they aren't without risks. And so we really have to develop this relationship, this trust with the patient, so we can get them to buy in on the effective treatment. So you may be familiar with step-up therapy, and that's something that over the years has been kind of the mainstream or the main way to approach treatment of inflammatory bowel disease. So you can see on the left there, we have the step-up therapy. So you start out with the 5 ASAs, and then if they respond to that, great. If they don't respond to that, maybe give them some steroids. If you have to do steroids more than a few times, well, maybe we should try something else. So maybe the immunosuppressant like azathioprine or methotrexate. And if they still don't do that, then maybe let's introduce these biologic therapies. Well, over the course of the last 10, 15, 20 years, we've really tried to almost flip that pyramid over and really try to hit people maybe doing a top-down therapy. And the reason we have wanted to do that is because what I referenced earlier, if we can change the course of the disease early, say, for example, in Crohn's disease, if we can treat them with biologic therapy early before they develop the strictures, before they develop the fistulas, so maybe we can decrease their risk for needing surgery in the future. But again, we have to look at the patient specifically. Not every patient needs to have biologic therapy immediately, particularly in ulcerative colitis. So for patients who are low to moderate risk, if we can stratify them, maybe they would be best served with azathioprine, or with the 5 ASAs. But maybe really the severe patients, those are the ones we maybe want to target to treat with biologic therapy first. So these are all these things that are going through us, the gastroenterologist's mind as we meet these patients. So here you can see just kind of an overview. for decades there really wasn't a lot to treat patients with, maybe a little bit of sulfasalazine, then along came prednisone, and azathioprine 6-MP. And then in the 90s, we're getting, more ASA choices, mesalamine products. And then at the end of the 90s, infliximab comes. That really is a game changer. We're going to talk about that a little bit more. And then there's this, in the last 10, 15 years, there's been an explosion. More anti-TNF therapies. You get adalimumab, certolizumab. Then you get natalizumab, which is an anti-integrin, and vedolizumab, which is another anti-integrin, and then ustekinumab, which is an IL-12/23 inhibitor. And even now you have small molecules like tofacitinib, which are the JAK kinase inhibitors that we will talk about. So really, even though we have a long way to go, there really has been an explosion and so many more options to treat with, even compared to when I started my fellowship back in 2011. So this is kind of this crazy little diagram that talks about all the different mechanisms of actions of these drugs. And we're going to take this down a little bit into different parts. But really what I wanted to show this is that, I think the more I take care of people with inflammatory bowel disease, the more I realize that what we're seeing, whether it's ulcerative colitis, Crohn's disease, indeterminate colitis, we are seeing the final common pathway of a syndrome that we see, okay? But just like what I hinted before, not all ulcerative colitis is the same. Why do we have patients who have pan-ulcerative colitis and you give them a little bit of mesalamine and 3 months later they're great? It's like they never had it. And they live the rest of their life on mesalamine and do fine. And why are there these other people who you throw them mesalamine, doesn't work, you give them steroids, it kind of works, you give them infliximab, that doesn't work, you give them vedolizumab, that doesn't work, and then they end up with their colon now. I mean, how are these the same thing? And I think part of that is because there's different mechanisms of actions. There's different cytokine pathways that end up producing the intestinal inflammation, but from a different path. And so the more options we have to control this and to help mitigate the inflammatory cascade, the more likely we are going to be able to help. So here's a list of biologics in IBD, and I've kind of separated them because some are approved in ulcerative colitis, some are approved for Crohn's, and some are approved for both. So I just wanted to kind of go over them and then talk a little bit about each of them in turn. So on the ulcerative colitis, we have the anti-TNFs. There's three. There's infliximab, adalimumab, golimumab. And then there's the anti-integrin vedolizumab, and then the JAK inhibitor tofacitinib, and then the anti-interleukin 12/23 ustekinumab. For Crohn's disease, it's a little different. You have certolizumab, which is approved for Crohn's and anti-TNF. In Crohn's disease, for the anti-integrins, you also have natalizumab, which is a slightly different anti-integrin. And then you have the and then ustekinumab, which is just recently, just a couple weeks ago, been approved for ulcerative colitis. It's been approved for Crohn's disease for a couple of years now. So the anti-TNF, I think this is the one we're all most familiar with. This is infliximab, adalimumab, golimumab, and certolizumab. This medication, binds to TNF and prevents it from binding to the TNF receptor, and then decreases the inflammatory cascade and allows for mucosal healing and then healing of the inflammation. So just a little bit overview. So, the biggest thing about the anti-TNFs is that, these are the pros. I've split it up into pros and cons, what we think about. So the pros, this is really tried and true. It's the oldest one that's been around the longest. It's a fast onset. It's one of the fastest onsets of action, so we can use it for induction and maintenance of therapy. There's different options. Infliximab is an infusion, and adalimumab and certolizumab are injections. So for people who we want to keep tabs on more, the infusion might be good because they can come into clinic and we know they're getting it. For people who want to travel the world and more trustworthy, the subcutaneous ones are really helpful. These have a systemic impact, which can be good for extraintestinal manifestations. And really, because they've been around the longest, we have the best data for almost everything, but including fistulas. Some of the cons, they are some of the most immunogenic, and that means that you can form antibodies to them and then get bad reactions, and you can also lose response to the drug. Cons also that, with this good parts of the systemic impact, it also has a negative impact of more risk of infection, malignancy, some neurologic side effects, and even some cardiac side effects. So that's some of the cons. Moving forward to the anti-integrin, so this is the vedolizumab and the natalizumab. This is a really neat medication. Basically what it does is it binds to the alpha-4 beta-7 integrin on the lymphocyte, and it basically blocks that lymphocyte from going into the gut. And so if you decrease the lymphocyte trafficking to the gut, that inflammation eventually over time slows down and heals. And this is really neat because it is gut-specific, right? So some of the things we talked about, the negative things of the anti-TNF with the immunosuppression, well, this has less immunosuppression because it is more gut-specific and less systemic side effects. So we talked a little about the pros of that. Because it is, because of the way of the molecule it is, it actually has decreased immunogenicity as compared to the anti-TNFs. Some of the con sides actually come apart from the same mechanism of action. Because it affects lymphocyte trafficking, its onset of action is slower because it doesn't do anything about the lymphocytes that are already in the GI tract causing the inflammation. So it can take several weeks, kind of like on the order of similar to how Imuran can take effect. It can take longer time. So because of that, oftentimes we have to give people longer steroids. It may have less impact on extraintestinal manifestations. And for the natalizumab, which is an alpha-4 beta, has alpha-4 beta-1 inhibition as well, it actually decreases the lymphocyte trafficking into the brain, and so you are increased risk for progressive multifocal leukoencephalopathy. The next one is anti-interleukin. So this is like the ustekinumab. This works by blocking the P40 heterodimer on IL-12 and IL-23 and decreases the inflammation that way. The pros of this, again, this is also these newer generation medications have decreased immunogenicity, which is really good. They're not as likely to form antibodies and decrease response. This also has a decreased risk of infection and decreased risk of malignancy. And as compared to the vedolizumab or the anti-integrins, it does seem to have a faster onset of action. Also, it does have more systemic impact, even though it does have less infectious risk, so it's very good for extraintestinal manifestations. Some of the downsides, you can't dose adjust it as much as the infliximab, which is a little downside, like if you want to escalate therapy. And the other downside is just, it's kind of too new. We don't know a lot of the impact on mucosal healing, impact on fistulas yet, and time will tell. But the good news is it has just been approved for ulcerative colitis, so we can use it for both Crohn's and ulcerative colitis. The next one is another really exciting one. These are the Janus kinase inhibitors, the JAK inhibitors. And tofacitinib is the only one that's approved now for inflammatory bowel disease, and it's approved for ulcerative colitis. And basically, they block the JAK-STAT pathway. This is really cool because this is not an infusion. This is an oral pill, and it's a small molecule. So it's not the other biologic. These other medications are all large proteins with quaternary structure. So you can't. We can reproduce it, but they're all a little different. And because they're so big, your body forms antibodies to them. But these small molecules, just like taking like an aspirin or something, or prednisone, your body doesn't recognize it. Your body doesn't form antibodies to it. So we can start and stop this medication if needed. We don't need to follow drug levels. So that's all really exciting. This also has a fast onset of action, so you can use it for induction and maintenance. The downside of it is that it does block multiple cytokine pathways, so there is an increased risk of infection. We can't use it with combination therapy currently. There's also, we have to follow people's cholesterol carefully, and there is on the higher dose an increased risk of blood clots which we also know in people with inflammatory bowel disease, there's increased risk of blood clots anyway. So just a little bit more here, just looking at combination therapy. So there is some data, that there's two main studies looking at this. There's the SONIC study looking at Crohn's, and then there's the UC Success study looking at ulcerative colitis, basically showing, particularly for moderate to severe inflammatory bowel disease, if you use an anti-TNF plus an immunomodulator such as azathioprine, your risk for a steroid-free remission as well as mucosal healing, your incidence is higher. So that's just what this chart is saying here. And the other one final thing that I want to kind of leave you guys with is that when we're taking care of people with inflammatory bowel disease, even though we do have many more options than we used to, we still need to be very good stewards with these drugs because there is a limited supply. So whatever we decide to do is whatever we decide to treat with, it's important to then make this agreement with the patients, give them these medications, and then agree to circle back in 6 months, 12 months, whatever it be, and is it working? If it's working, great. Do a scope, do some imaging, do some fecal testing. If inflammation's controlled, then awesome. Keep going. If it's not, then adjust it and maximize what you can do, and then check again. Thank you.